Last but by no means least, we're going to enter the world of looking at transplantation and how we get the organs that we so vitally need. So we're going to go across the pros and cons of using the NRP, or DCD as they call it, system. So we're going to have two wonderful speakers that are going to take opposing views, mainly for the discussion. So don't necessarily think that everything they say is what they truly believe and it's not going to start a war, but they're going to put on 2 points of view. And the idea of this is to make you think, to make you wonder what is your position, what do you believe in, what do you think is the right thing for our profession to be doing. And this could be a moral thing, this could be based upon your religious beliefs, whatever. Now I'm going to try and handle that as delicately as I can, bearing in mind that I'm a very sarcastic atheist Englishman. So this could go horribly wrong, but I will try and keep things moving in a way forward. So first of all, I'd like to bring up Bharat Datt, who is going to go with the ethics of the con.
All right, guys, I was taking a left in the hospital system, and I had a green left signal. And I see this old lady trying to cross the street, okay? And I had 4 cars behind me honking. Now, those 4 cars are probably of nurses and doctors who are going to save a life, right? What should I be doing? I'm legally right. I got a green left turn signal. Should I run the old lady down for the greater good behind me? What do you guys think? Well, this is what we're going to talk about. And before we go into the con of the ethics of DCD, let's revisit death and its definition. So I want to start with a video. So that's what we want to talk about. Is his brain okay? It's a very qualitative statement there. You know, how do you make sure a brain is okay, especially to an intubated patient? So one of the first studies I researched on was ethical issues in Chile. And that brought forth a few very interesting statements. First of all, we follow the Uniform Determination of Death, which was made in 1980, right? Now, this determination of death says you need to be either brain dead, which means you're going to quantify it by looking at Doppler flow to your brainstem, or through an arterial line, or you don't have any reaction, any neurocognitive function to your brain. Again, certified by a doctor, by an MD, one or the other. And irreversible cessation of circulatory and respiratory function. So obviously, the patients usually undergoing DCD are on a ventilator. So they're apneic, they don't have respiratory function. But if they don't have brainstem function, we say they're dead, right? According to accepted medical standards. What is that? Not many people know. And then, once they're certified as brain dead, there's got to be a no-touch period. Can be anywhere between 5 to 30 minutes. What is that no-touch period? It's arbitrary, right? So say you have a patient in your ICU on a ventilator, and he's been certified as brain dead. So that patient experiences an OPO, an organ procurement organization, who comes in, they say yes to the donation, they take this patient to the OR, they disconnect the vent and wait for a flat ECG in 5 minutes, which is the current norm in the United States. And if they see a flat line, they reconnect the vent, put him on a cardio help or some kind of ECMO machine. And then what do they do? Let's find out. And that's where I have a problem with. So barriers to organ donation. I'm not against organ donation. I think it's a good thing when you save a life. But you can't make decisions based on greater good, because that is a slippery slope. So there's ethical issues with informed consent. How much do you tell your family? So for example, when your patient goes into the OR on a ventilator and they remove that vent, and he doesn't have asystole in 5 minutes, what do you think they do? They put him back on the vent, they take him back to the ICU, and they try again in 7 days. Would you want your family member to go through that? And is he or them told about the process? I'd say probably not. So here's the question. Is it withdrawal of care, or is it acceleration of death? Because sometimes it is. The next paper I got to read, and I'm not an ethics guy, so I really had to ask people a lot of questions, and I appreciate a lot of people coming forth with information. And this is about ethics in the United Kingdom, and it talks about the reintroduction of DCD has become the focus of a bioethics controversy. Since it necessitates intervention. So this is important. You're doing an intervention. So what happens regularly in DCD, and my colleague can correct me if I'm wrong, is when you go to the operating room and you're certified brain dead, they're going to do the no-touch period, put you on a cardio help, and then clamp your head vessels, which is the carotid and vertebral arteries, so that your brain can never be alive again. To me, that is an intervention. Also, trying to reestablish circulation to the donor is an intervention, because you just had him on an asystole. Therefore, with the asystole, there is no flow. And you reestablish flow with the purpose of harvesting those organs. To me, that's a big no-no. That can't happen. It's not something you would want to your own family. The next thing I read about is there is a reasonable disagreement among physicians, philosophers, and public. And no, I'm not talking about Epicurean philosophers in the 18th century. I'm talking about philosophers living in the United States today, and the court of law, the court of public opinion. These are things we have to include when we want forward movement in our profession. So medicine is not responsible for everything. There's a lot to do with decision making. And I don't know if anyone here from California? Anyone from California? Okay. So anyone heard of Jahi McMath, the girl who was 4.5 years on life support, and it was withdrawn ultimately from an order from the court of law? I'm not pro and con any of that, but this girl had a tonsillectomy, and she died post-tonsillectomy. So to me, as a member of the public, I can understand why the hospital wanted this case to go away. Like, who dies after a tonsillectomy? Right? So what I'm trying to ascertain here is, what is death? Do we actually know what is death when we see it in the intensive care unit? Especially, I work with kids. You want the kid to be alive. You don't want them dead. How can you justifiably 100% say someone is dead? Maybe not. So the other thing I wanted to talk about is, everyone has experienced a healthcare system. We have 50 states with 50 different healthcare laws, probably also about organ donation. And on top of that, we have 54 OPOs in this market. And if you look at this slide, most of them are underperforming, which I believe is actually a good thing, because we haven't really streamlined the guidelines for organ donation for DCD. Standardization is important. We need to make sure people are not taken advantage of. Equity is important. Who is donating and who is receiving? That's important. And so this United Network for Organ, these OPOs are overseen by UNOS, which is the United Network for Organ Sharing. And in turn, these are overseen by HRSA, or the Health Resource and Service Administration. Anybody delayed on a flight? There you go. Stood on the tarmac for 5 hours, yours truly. Complained to the FAA? When do you hear back? 6 months. What do they tell you? Sort it out with the airline. Think about trying to complain in this situation to these people. It's not going to happen. So non-Potomac Regional Perfusion is in the news. It's on LinkedIn. Everyone's talking about it. But this is a very good paper by John and Twistle. And he talks about mechanic and circulation, what I talked about, blood flow reestablishment to somebody whose blood flow has stopped because of asystole. I mean, to them, that's an intervention. To me, everything is an intervention, especially clamping the head vessels. Also, if you go and look at the American College of Physicians and their ethics and determination of death, they talk about this. The main concern associated with TA and RP is the ethical question for the determination of death. When do you determine a patient is dead? When the dying process is interrupted and the patient might be alive. Is the patient dead? Or are he or she alive? Well, you just got to go on Dr. Google.
We're going to talk now about that 13-year-old Alabama boy's incredible recovery. Doctors told Trent McKinley's parents their son was brain dead. His parents even signed the papers to donate his organs, but then they say a miracle happened. ABC's Lindsay Davis is here with more. Good morning, Lindsay.
Good morning, Michael. There is one word that people involved in this story keep using to describe it: miraculous. One of the trauma surgeons told us the teen's heart stopped for 15 minutes. The doctors believe there was nothing else they could do. That's when the family says there was a divine intervention.
Well, divine intervention or not,
we're going to talk now about
that kid was alive, and they declared him dead, and he became an organ donor. And this is what I'm talking about, is we are not really sure what death means. And to go ahead and ligate someone's arch vessels, I think that's going too far. And if you read this paper, it says that just because you ligate the carotid artery and the vertebral artery doesn't mean you've stopped blood flow to the brain, because there's an artery called anterior spinal artery which supplies blood flow to the medulla. So whether you're completely ischemic or not, no one is sure. Just like we're not sure of anything else. And here we're talking about the purpose of ligating the cerebral vessels is to create and maintain the state of death. That goes against DDR, or dead donor rule. You are creating and maintaining the state of death. Big no-no. And any action that is designed to create or accelerate death during withdrawal or life-sustaining treatment is akin to active euthanasia. Search these words: passive and active euthanasia. And the most important thing is, why are we doing this? So I came across this paper from Denise Dudzinski, and she's a big name in ethics. And we're talking about patient advocacy and equity, like I said, right? Like, who is donating organs? Are they poor people? Are they brown guys like me? Like, who is getting the organs and who's donating organs? Is there equity in that? Just because you're poor, you're going to be dying of drug overdose, you're going to be a donor? And if you're rich, you're going to be a recipient? Like, there is not enough data to talk about equity, but it's an important ethical question. Is there equity in our transplant, DCD transplantation process? It's very important. And this paper says the OPO is responsible for obtaining a consent from the donor surrogate to any testing or interventions related to organ placement for preservation, is what I said. How much detail is shared in that? Are you going to tell them that if this doesn't work, we're going to try again 7 days later? Sorry, you can't get the body. These are important questions to talk about. And then, like I said, our poor people, our people stigmatized, people who are dying of drugs, people in prisons, are they the donor network for us? And is it right for us to take organs from them? All right? So DDR, dead donor rule, protects marginalized populations. But more importantly, I think one of the things mentioned in this paper is the reason we clamp the head vessels is to make sure that the person is not aware. Hold on a minute. Hang on. I thought this person was dead. Why are we talking about awareness? Why are we talking about awareness? Are you kidding me? This patient is dead. You just certified he's dead. But now you're clamping his head vessels because you don't want awareness? What the heck are we talking about here? When I perused some information from my European peers, I found that that was a much better way of declaring dead. They have, as you can see, a number of processes which have to be met for someone to be declared dead. And I would rather have this kind of criteria to declare someone dead. And most importantly, this is from the Swiss Academy of Medical Sciences. But most importantly, you know, in addition to the clinical exam, cerebral circulatory arrest must also be demoed by appropriate additional tests. So this is very important. You know, is there flow to the brainstem or not? And how do we do this? And most importantly in this paper, these measures cannot hasten death or lead to a permanent vegetative state. So clamping the head vessels, no, no, no. I was talking earlier about standardization. I think standardization is important. You know, there's 50 states here. Are we standardized? Probably not. 54 OPOs. Let's look at Europe. For example, you have these different countries, right? You have a wait time between 5 minutes and 30 minutes. How do you determine the wait time? It could be echocardiogram, it could be just plain old ECG, or it could be invasive blood pressure monitoring, or all three. We haven't really figured out a way to make sure someone is really dead. And we're trying to take someone's family away just because we want an organ donation. I think that's wrong. The ethics of donation are very important. I think there's a conflict of interest when someone who needs an ICU bed certifies someone is dead, right? If you have an intensivist, so there's two doctors who need to certify medical death. One is obviously the intensivist who's taking care of the baby, and one is an OPO doctor. We're not going to go to the OPO doctor because obviously there is conflict of interest because their business runs on organ donation. But intensivist, second intensivist, cardiac surgeon, cardiac anesthesia, anybody wants that ICU bed. That is a clear conflict of interest to me. So the other part is the money, right? 32% of DCD donors do not progress to donation. We already have a cash-strapped system. We already have an expensive system. Can we afford to spend money on something which will not work out and which we are responsibly unethical about? I came across this book in my local library. It's about trafficking, but if you go to chapter 4, I read the story about Roma tribe boys being trafficked from Albania into northern Greece for begging. So the Greek government went in this educational drive to educate people. Hey, don't give money to these kids. They're being trafficked. Guess what happened? A few months later, they started finding dead bodies of Roma children. These are not just dead bodies. They were empty shells. They were harvesting organs from these kids. What I'm trying to say here is we want to do good, but we are not always sure about the outcome. We all are well-meaning for DCD, but is the system just going to take over, or are we going to have control? Right? Anyone watches National Geographic? Mariana Van Zeller. She's got a lot of things. For lack of time, there's a number of videos I can show. There's a video about a funeral home trafficking in organs for education without the consent of the family. But I want you to see this video, and I'm almost done, Richard.
Quisieran que no tienen una promoción.
Sí, ahora me mandaron para la frontera de Panamá.
¿Y qué pasa ahí en esa frontera?
Pasan coca, inmigrantes, órganos. Entonces me tuve que estudiar todo eso.
Looking at a map, it's easy to see why the cartel has placed the commander here and why it's one of the world's hotspots for smuggling. There are no roads connecting Colombia and Panama. Anybody headed north must travel by boat or pass overland through the Darien Gap, a 100-mile journey through one of the most treacherous jungles in the world.
¿El negocio de órganos es nuevo o ya existe mucho tiempo?
No, eso por ahí está nuevo.
Controlling the Darien Gap is crucial for the cartel, which collects a so-called tax on drugs and migrants. And now, I'm being told, on human organs.
¿Y cuál es su trabajo en ese negocio? ¿Usted está envolvido?
No, eso no es lo mío, eso no es lo mío.
So where do you think the demand for organs is? In America and the Western world. Where do you think these organs are going from Central America? They're coming to Mexico, and they're going to be trafficked in the United States of America. So we have to be careful in developing guidelines and strict criteria in declaring someone dead for organ donation after DCD. That's all I have for you today, folks. Thanks for listening to me.